Okay, so what? So this is Linda. Hello.
Hello.
Hello. So Linda comes to us with concerns about the tear trough area. So especially when she gets tired, she gets these dark circles underneath her eyes, and she notices that over time she's had some volume loss in the area, and she has an indentation in that area. And so what we want to do is fill that volume loss, replace that lost volume, and blend the contours of blend the contour of her cheek into that of her lower lid. When I consult with Linda, what I do is I show her with a mirror what it's going to look like when we treat it. And the way I estimate is I'll press a little bit down here, forcing the fat up a little, forcing this superficial cheek fat up a little bit to fill that tear trough, and so she can see what the results are actually going to look like in the tear trough area. And that usually is a nice estimate of what it looks like when it's filled, so they can understand. In terms of the anatomy and considerations of where we're going to inject and how we're going to do it, the reason that the tear trough is formed is because the superficial orbital fat has descended off of the orbicularis oculi. And what you're seeing here is, so you're seeing a thinning of the skin, you're seeing a thinning and a descent of the fat, and you're seeing a thinning of the orbicularis itself. So this indentation forms in the junction between the cheek and the eye, and as time goes on, less and less tissue is on top of the orbital rim. In terms of any kind of danger, you have the angular artery that comes across here and right into that area right near the tear trough. Where the angular artery lies is it lies just underneath the orbicularis oculi muscle and just over the levator labii superioris obliqui nasi muscle. So in between these two muscles courses the angular artery. In order to make this as safe a procedure as possible, I like to go right on top of the bone, on top of the orbital rim, and place the filler in that plane. Number one, I am lessening the chances of the Tyndall effect, and number two, I'm also lessening the chance of encountering any major vessels in that area, since I know they're going to be above me. Over years of injecting the tear trough, I noticed that very clearly the tear trough is a privileged area. It's an area that holds on to filler for, no matter what the filler is, for a very long period of time. I find that when I inject hyaluronic acid, at first I started with Juvederm, and then I've tried others. But when I inject hyaluronic acid into the area, it lasts for a very long time. Full strength Juvederm, I've seen people come back 6 years later and they still have that fill. So I tried other ones like Restylane and Belotero. I'm not quite sure they're going to have the same kind of duration. So what I'm using now is a dilute form of Juvederm, where I'll take Juvederm Ultra, mix it with pretty much half and half with saline, and add a little bit of lidocaine and epinephrine for the vasoconstricting effect. It's a very smooth kind of effect, lasts for a very long time, it's reversible, so it combines all the things that we really want to see within a filler. What we've been doing is icing for a while, and again for vasoconstriction, not really for pain control much, but really more for vasoconstriction. There is not that much pain in this region, so I tried to do it without numbing cream. I don't find that numbing cream is really necessary here. Okay. Now, keep your chin down. Look up just with your eyes. As she looks up, she rotates the globe up, and you can really see that tear trough outlined very nicely. So that's a good gauge of where you want to go and how much you want to fill. Okay, so let's start from over here. Go ahead and close your eyes. I will place the needle through the skin, hit bone, pull back, reposition the needle. I'm now in the very deep layer, right on top of bone, and then I'm going to put little stripe of filler on top of that area. And you'll notice in a second I'm going to mold the filler. The filler molds very well. This dilute form of Juvederm molds really well, and it really contours nicely to the contours of the structure of the underlying structures. So I'm just putting little bits of filler in here, and that contours nicely. When I'm injecting, my needle is never in one place. It's always moving. I find that to be the most reliable, one of the more reliable safety measures, and I like to call it universal injection precautions, is that whenever you inject, you're moving the needle, so that if the needle is in an area that you don't want it to be in, because you can't see under the skin, you don't know exactly where that needle is. If the needle happens to be in an area you don't want it to be in, then at least you're in motion, and you're never going to deposit large amount of material into an area that you don't want material to be in. Open your eyes. Okay, so we already have very good progress. We have a nice fill here. Let's go over here a little bit. The other precautions that I take in terms of safety is that I never push hard on the plunger, so that I'm never putting filler in under pressure. When we see really bad adverse events, such as blindness, necrosis, and stuff like that, we see that in the context of filler going in under extreme pressure. In order for the filler to get into the retinal vasculature, or the ophthalmic vasculature, you have to put it in with enough pressure to overcome systolic blood pressure. And so if you are just injecting gently, you don't have that kind of danger. Okay, open your eyes. One of the other things that I keep in mind is where the orbital septum is. If I stay on bone, that means that I am anterior to the orbital septum. If you're posterior to the septum, then you're putting filler into the orbital fat, so the post-septal orbital fat, and you don't want to do that, because once the filler is in there, you no longer have an ability to mold the filler, and you can end up with visible lumps and contour abnormalities, which you really don't want. Okay, open your eyes for a second. Good, that's much, much better. And you can see here that we're doing quite well. Turn this way. A little bit right over here, and then we should be all done. So little stick here. Open your eyes. Good. So that's really nice. I like that. I certainly don't see any major bruising. And you can compare between the two sides, and you see what a nice effect that just filling that little bit into the tear trough has on her whole face. She looks less tired. This area looks more smooth, and she looks a little bit younger, which is nice.
Always nice.
So, let me just put one little dot right here. Stick here. So universal injection precautions: always keep the needle moving when you're injecting. Always use the smallest gauge needle possible. In this case, I'm using a 32 gauge needle, and I find that to be quite comfortable injecting a dilute product such as this. The other component is don't put a lot of pressure when you're injecting, so that even if you're in the wrong place, at least you're not putting a whole bunch of product into that place, and you're not putting it under extreme pressure, so that you're not overcoming systolic blood pressure, and you're not pushing product retrograde and up into vasculature that, such as the ophthalmic vasculature, which you don't want. Open your eyes. That looks really nice. So let's go over to the other side and finish things up. Go ahead and ice the other side. That's good. Let's not actually like that. Look up. So we'll start from here. You can see how there's the volume loss starts over here and continues all the way around, and up in here just a little bit. But this is the major area. What I'm not shooting for is to have a completely smooth transition between her lower lid and her cheek, because here she has some herniated fat that you can see through the lower lid. We're not going to be able to really blend that completely in, but I think so she's still going to have a little bit of fat visible pooching out, but this will be at least a smoother transition, if not a perfectly smooth one. Okay, let's go back. Let's turn this one. Okay, little stick here. And I always know where that orbital rim is. I'm always palpating it so that I know that I'm in a safe place. Open your eyes. Stick here. And I'm injecting very little bits each time. 0.1 cc, 0.2 cc max. Usually it's about 0.1 cc per injection. And you see how nicely it molds. It really contours well into that indentation of the tear trough. So far I've used 1 cc of dilute Juvederm, so I've used half a cc of Juvederm and have combined with half a cc of saline plus 0.15 of lidocaine with epinephrine. Little stick here. Can you see that? Open your eyes. Come forward. That's a nice change. Little stick here. And if there's issues with this, I found that dissolving it with hyaluronidase is really very simple, not a big deal. But the reason why I'm using dilute Juvederm, by the way, is what the saline does is hydrate the hyaluronic acid of the Juvederm. The point that why, open your eyes, come forward. That's good. Okay. The reason why Juvederm in the tear troughs fell out of favor in the first place is that people were coming back with a lot of swelling, because the Juvederm, being so hydrophilic, absorbed a lot of the patient's own water from their tissues and wound up looking bumpy or swollen, and it would swell or go up and down depending on the patient's state of hydration. So one morning it could be real puffy, one morning it would be not so puffy. So this is a way around that situation by pre-hydrating the Juvederm, so when it goes into the tissue, it's already got lots of water around it, so it doesn't absorb any water from the surrounding tissue, and it doesn't have that kind of swelling or bumpiness that we saw. Okay, open your eyes. Come back. And a critical aspect of the consultation process is to make patient understand that this is a procedure for the tear trough hollow, not for the fine lines under the eyes. And those fine lines, they'll improve a little bit as we fill the hollow and as we plump up the skin. But it's really not but they'll still have those fine lines afterwards. Come forward. They just won't, in my opinion, those fine lines just won't matter as much. We can see here, jump back, that she still has a little bit of fine lines. Drop your chin down. She still has a little bit of fine lines, but it's not a big deal, because when those tear troughs are gone, she looks so much better. Okay, open your eyes. The area lateral is the lateral aspect of the tear trough is especially tricky because the septum actually comes a little bit anterior in that area, and so it's actually easier to get behind the septum there than it is in the more medial aspect. So you have to be a little bit more conservative and inject maybe not right on top of the bone, but a little bit inferior to the bone, like in this area, and then push the filler up to make sure that there's a nice smooth contour. And then what I want to do is go a little bit over here. Again, very small needle, very light, slow injections, always moving the needle. How is this in terms of discomfort, Linda?
It's not uncomfortable at all, actually.
Okay, it's not a big deal, right?
No, totally not a big deal.
All right, open your eyes. That's really good. I think that's pretty perfect. So we've used 1.65 cc's of dilute Juvederm. Here's the mirror. So here's what it looks like. I don't see any major bruising at all. I see it much smoother. This will go down a little bit. This is a little teeny bit swollen. That'll go down. I'm going to just put a little bit right over here still. There's still a little teeny hollow area right there. But otherwise,
so much better.
So much better. Yeah, this is really nice. Okay. Little stick here. Can you see it? Yeah, okay. Again, I'm deep. I'm moving. Okay. Great. And then one last point is that when we do these injections, and people have a little bit of fat herniation in the lower lid area, we're injecting next to that area of fat herniation. We're manipulating the injections. We're massaging it, etc. So it's not uncommon for that area to actually become swollen. So it's important to not over-inject, because a lot of times when I inject the tear troughs and there's an area of pooching of fat herniation over it, that area of fat herniation swells. So I take that into account, and I try not to over-inject the tear troughs to compensate for that swelling. I'd rather inject it to where it looks good. Even though it's swollen, it might not be perfect. Have them come back 3 weeks later, and then once the swelling has come down, and take a look at it, if there's still an area that I want to add to it at that time, I can add to it at that time. But you want to be real conservative with the tear trough, because you do get swelling in that area. Okay, thanks.